Hello everyone, I'm Beth Britton. I support Dementia Community with their communications work. Welcome and thank you for joining us for our first June webinar. Before we get on to the topic for today, I wanted to briefly explain a bit more about Dementia Community. Dementia Community is a charitable community benefit society, a membership cooperative that provides learning and networking opportunities for the dementia care community. We are an independent voice and inclusive organisation aiming to help all of our members feel connected, informed, inspired, empowered, purposeful and engaged in co-produced changes that improve everyone's experience of dementia, both in care and in wider society. This webinar is just one example of the many ways in which we do this. Community members own a £1 community share in Dementia Community, and membership is open to everyone. So if you aren't already a member, do join us. We'd also like to highlight a new initiative, which is the one that's on your screen in front of you. So this is called Editor's Pick. It's from the Journal of Dementia Care. It's a free article chosen by the editor of JDC, shared to give you a taste of the content of the journal. Please use the QR code on the screen if you would like to read that article. And remember, if you are a member, so if you purchase that £1 membership, you are then entitled to a 25% discount on a subscription to the Journal of Dementia Care. So if you enjoy the editor's pick, do consider subscribing. We also have 2 free issues, complete free issues available of the Journal of Dementia Care as well. So Equality, Diversity and Inclusion, a special issue, and Celebrating the Arts in Dementia Care. We will share the links for those in the chat once the webinar's underway. And we also have printed copies available, and we'll provide you with the email address so that you can obtain those if you would like to. So let's move on now and introduce our webinar for today. So changing the conversation about hearing and dementia to drive positive action. I will introduce you to our speakers shortly, but firstly, some brief housekeeping. We are recording this webinar, so if you don't want your face on the recording, please turn your camera off. Please use the chat for your questions. We will have a Q&A and discussion after the presentation, and we'll be keeping an eye on the chat. We hope to have some live participation too, so if you'd like to ask your question yourself, please do raise your hand when we get to that point, and we'll be happy to hear from you. Afterwards, David will email you a link to the recording, which will go onto our YouTube channel, Dementia Community, and other related information will be in that email as well. So do look out for that. So without further ado, let me introduce you to our speakers for today. So Dr. Helen Henshaw, Principal Research Fellow, NIHR, Nottingham Biomedical Research Centre at the University of Nottingham, and Dr. Hannah Semeraro, Head of Insight and Evidence at RNID. Apologies, ladies, for getting your names all mixed up. Helen and Hannah, welcome. It's wonderful to have you with us. Such an important topic around hearing and dementia. Really looking forward to hearing from you both, and over to you.
That's brilliant. Thank you, Beth, and thank you for the opportunity to present. Okay, so thank you. So first I'm going to talk to you a little bit about hearing loss, why hearing loss is important, why it's typically under-addressed. I'm going to then talk to you a little bit about how hearing loss and dementia are associated. And then I'm going to pass over to Hannah, who will talk a little bit about changing the conversation around hearing and dementia. Typically looking at how we can have more positive messages to make sure that we can drive positive action. So it's a little bit of an overview of what we're going to do today. Okay, so hearing loss. Well, we've got a figure on the screen of 18 million people that are affected by hearing loss, so it's quite a lot. It's a progressive long-term condition, often without cure. And it represents the 3rd global cause of years lived with disability. The estimates that we have here, the 18 million people, is actually an estimate for 18 to 80-year-olds. So it's likely an underestimation because hearing loss and age go hand in hand. So those over the age of 80 are highly likely to have hearing loss, and they will add to these figures. The vast majority of people affected, so about 92% of all people with hearing loss, actually have mild or moderate losses. But those terms are actually a little bit misleading, because people with mild and moderate hearing loss can actually experience substantial communication difficulties. And hearing loss isn't binary, it's a progressive condition, it's on a continuum. So people who develop hearing loss, their hearing will continue to decline over time. So approximately 1 in 3 adults are affected, probably more. And these are people who have hearing loss in at least 1 year. But when we think about hearing, we probably think typically about the ear, but hearing is only the precursor to listening and communicating. And for that, we really do need our brains, our cognition, to be able to work out the meaning of sounds and to kind of take that forward. So the ear is the beginning of a pathway to hearing. So it provides availability to sounds or cues. We can then listen using those cues for a purpose, and we can comprehend by creating meaning and mapping those cues to stored knowledge. And communicating is a meaningful interaction that's mediated by those cues. So you can see there's a lot going on beyond the ear. So the typical gold standard treatment for hearing loss, or management, should I say, because we can't cure hearing loss, is the provision of hearing aids which provide access to sound. However, people often don't seek help, or when they do, they delay their help seeking for a period of up to 8 to 10 years. So only approximately 1 in 5 people who could benefit from hearing aids actually have them. For those who do obtain hearing aids, there's an estimate of non-use of those hearing aids of between 3 and 24%. And there are many reasons for this, but ultimately hearing aids cannot restore lost hearing. And so expectations can be unmet, and problems listening still remain, especially in noise. So hearing aids provide access to all sounds. They amplify all sounds, not just speech, and that makes listening and communicating in noisy environments particularly challenging still. However, when people do receive hearing aids, the earlier they receive them in their hearing loss journey, the better their outcomes. So that's really important. And so in recent years, over-the-counter devices have become much more prominent, particularly since the change of legislation over in the States. And these could help people on their first step to obtaining and seeking hearing intervention. But uptake hasn't been as high as expected, and more research is needed to kind of look at the benefits and the provision of over-the-counter devices for people with hearing loss. So where does that leave us? Well, there's a huge unmet need, and unmanaged hearing loss is associated with several really negative consequences. So people who haven't solved their hearing loss, who haven't managed it with any hearing devices, will continue to experience problems with listening and communication, and that can strain relationships at home and at work. It can lead to social isolation and loneliness. Hearing loss is associated with lower income and employment challenges. It can lead to increased depression, absolutely leads to reduced quality of life, and it's also associated with increased falls, cognitive decline, and an increased risk of developing dementia. And hearing, it's our social sense. So this quote comes from Helen Keller. It's often brought up when we talk about hearing loss. But Helen Keller suffered from both blindness and hearing loss. And she talks about blindness separating people from things, but deafness separating people from people. So losing your hearing can be absolutely devastating to social connectedness. And it's not just talking to other people that is missed in hearing loss. We have an illustration by one of our patient research partners, Jean Strauss. She developed this, and it was kindly illustrated by her daughter, Annie Rickard Strauss. And she missed the sounds of nature, and that's something that when she received her hearing aids came flooding back. So in Nottingham, we've developed some tools to try and help people to use their hearing aids, particularly when they first get prescribed. This is a toolkit, so you can just see a screenshot here that we developed, that was funded by the National Institute for Health and Care Research and developed in collaboration with the charity RNID. It's called Get the Most from Your Hearing Aids, and it goes through 6 steps to help people really try and understand hearing loss, understand hearing aids, to plan, to set goals, and to learn communication tactics, which hopefully we think will support people through that journey. It's based on behaviour change principles, and it includes videos from people with lived experience, just sharing their stories to help people along their path. And we've also got an industry-funded project looking at the feasibility of text messages to support people right from the very beginning of their audiology pathway. So when people are first diagnosed with a hearing loss, the text messages support them. They inform, prepare, and support people all the way through their journey, through fitting of their hearing aids and beyond. So we're just about to get that up and running at the moment. So hearing loss and dementia, how are they associated? Well, there's a dual challenge really when we think about how these two things are linked. So we know that people with hearing loss are at an increased risk of developing dementia, but we also know that there is a high comorbidity of dementia and hearing loss. So dementia risk is elevated, and it also rises with hearing loss severity. I'm going to show you that on the next slide. And dementia comorbidity is really high. So around about, as an example, in care homes, 70% of care home residents will live with dementia typically, and around 75% also have hearing loss. But it's important to know that comorbidity can often go undetected, so you wouldn't necessarily think that these people have both, and I'll talk a little bit more about why that is the case in a moment. What I've put on the screen here are 2 different resources that might be of interest to people who want to learn more on this topic. So the first is an industry-developed masterclass called Listen to This, which goes through, I believe there's 11 different videos talking about all of the aspects of linking dementia and hearing and what can be done about it. And then for a more lay audience, we have a really nice illustration developed as part of our James Lind Alliance priority setting partnership, led by my colleague Etna Heffernan, who I believe is on the call. So hi, Etna. And this is a really nice illustration animation video, just going through kind of how the 2 conditions are linked, and that can be shared with patients and the public. Just a note about the Listen to This masterclass. The picture you see there is my first ever modelling gig, and it turns out my best feature is my right ear. So I'm really proud of that. So hearing loss severity increases with incident dementia. So hearing loss severity increases incident dementia risk. So as I mentioned on the previous slide, as hearing loss gets worse, the risk increases for hearing loss, the hazard ratio, if you like. So risk increases by around about 27% for each 10 dB decibels of hearing loss as that goes up. So what this means in real terms is that somebody with a mild hearing loss will be at 2 times the risk of developing dementia over their life course compared with somebody without hearing loss, and that rises for 3 times for moderate hearing loss and 5 times for severe hearing loss. And what do we mean by risk? Well, one thing that you may have come across when we think about the link between dementia and hearing loss is this figure from the Lancet Standing Commission on Dementia, which is often pulled out to talk about this factor. So this looks specifically at something called population attributable risk, and it suggests that hearing loss in midlife is a potentially modifiable risk factor for the development of dementia at around about 7%. So what does this actually mean in real terms? It ranks up there with the top of those potentially modifiable risk factors that you can see on the screen. But the population attributable risk factor is a number that's quite hard to understand, I guess. And it's really important to note that it is actually dependent on all of the other risk factors in that model. It can change based on which risk factors are added or removed. It can be changed by the number of hearing studies that are included in the model. It can also be changed by inclusion criteria. And over time, the reference data that goes into the model has changed. So you may see that across the 2017, 2020, and 2020-24 models, the population attributable risk fraction has changed from 9.1% down to 8.2% and currently stands at 7%. We also need to be clear that the studies that feed into this model are actually largely cohort studies, so they're observational in nature. So we can't really infer causality, but it's a really important starting point, and it's elevated the discussion in this area substantially so that we can start having a look at what can be done. So how is hearing loss and dementia linked? Well, there are a number of proposed mechanisms linking the two, and it's highly likely that there's some kind of overlap or comorbidity between these mechanisms, given the umbrella nature of what dementia is and the umbrella nature of how hearing loss can be caused. But they can be broadly categorized into 4 different aspects. So either hearing loss causes dementia, or it is a catalyst for dementia, so it contributes to the development. It could also be a consequence of dementia. And finally, there could be some kind of shared cause that kind of targets both of them, maybe a vascular effect. But one of the things that's really tricky to see is that there are often overlapping symptoms between dementia and hearing loss that can lead to something called diagnostic overshadowing. So earlier I spoke about the fact that comorbidity isn't always identified. And this is because some of the difficulties that people face from dementia symptoms can also be the difficulties that they face through hearing loss symptoms. And these include things like communication and social interaction difficulties, difficulty concentrating, discomfort or annoyance in noisy places, withdrawing socially, depressive symptoms and fatigue. And when we think about social interactions, there are many different common challenges for somebody who lives with both dementia and lives with hearing loss. So you might recognise some of the behaviours on this figure in a dementia population, but you may also recognise that in a hearing loss population. So how do we detect hearing loss in people living with dementia? And there are a number of things that we need to be aware of here, and it's often the case that hearing care professionals, the healthcare professionals may not be necessarily aware or of the importance of the association between the two conditions. So the first aspect is raising awareness of the association, and to be dementia aware, to be deaf aware in dementia. I've got this the wrong way around. So if we're thinking about a population of people living with dementia, if we're deaf aware, we can then try and pull out some of those shared symptoms and just double guess, is this symptom a symptom of dementia that we would expect, or is there something more going on and should we test their hearing? One of the things we could look at is targeted screening, population level screening. So we know that population level screening for hearing loss is highly likely to be a economic thing to do. However, it's not currently recommended in the UK, and it would actually require a lot of resource and cost to get that up and running. However, if we think about targeting hearing screening to people who may be particularly at risk of developing dementia or who already have dementia, then we can actually think about maybe scaling back that screening programme to something that will be much more targeted and useful. In the absence of any kind of population or targeted screening across the UK, what we can do is look at things that already exist to be able to test your hearing online. So the RNID have an online hearing test that's been taken by over 600,000 people already, freely available on their website, and takes a couple of minutes, just 3 minutes, to be able to come up with a score that will give you an indication as to whether you need to go and have more assessment done. So the other way around, if we're thinking about the detection of dementia in people living with hearing loss, We want to again raise awareness of the association and make sure that people are dementia aware, this should say, because I have it the wrong way around. One of the things that's really kind of come to the forefront in the field is looking at how cognitive screening tools are designed and developed. And this is an example of the Montreal Cognitive Assessment that has been adapted for hearing impaired people. So maybe the use of tools such as this that have been specifically adapted for people with hearing loss is a good thing to be rolled out universally, particularly because we know that the age group is highly likely to be suffering from hearing loss when we're thinking about an older adult dementia screen. Dementia clinic. So what we can also do is we can ask or assess cognition in audiology clinics potentially, and this is something that research has looked at, which I'll talk about in a little bit more detail. So if you attend an audiology service and you get asked about your cognition, you might actually be surprised because as a member of the public, you might not be aware of the link. However, my colleague Emma Broom conducted a study, a survey, followed up by workshops with patients and the public to ask specifically whether this would be acceptable. And her findings are that 92% of those people attending audiology for hearing assessment would find it acceptable to be asked about their cognition or to complete a cognitive screen, providing that the audiologist had suitable training to do that, and providing that sufficient explanation and justification were provided as to why it would be beneficial to do a cognitive screen. However, it's acknowledged that additional time, staff resource, clinical guidance and training would be needed to do this. Rohani Omar has also conducted a feasibility study of this approach. So she's based at UCL, and this publication came out relatively recently. So a feasibility study of actually implementing a cognitive screen in a hearing clinic. And she showed again that it would be feasible. However, additional staff, time, resource and training would be required. So an alternative to this, it would be to ask about or to assess hearing in memory clinics. And that would probably be much more straightforward. If somebody is required to do any kind of assessment, you want to check that they can hear and see it. So that would be much more straightforward to implement. And there are also standardized measures to assess hearing with handheld devices or apps. So when we go back to thinking about the proposed mechanisms linking hearing loss and dementia, this is important if we think about once we've detected that somebody has both, what can we do about it? Or once we've detected that somebody has hearing loss, what can we do to try and mitigate cognitive decline? And the provision of a hearing device is potentially going to be beneficial for these two top proposed mechanisms. It's unlikely to help at all for a consequence mechanism, but if we think about hearing loss being either the cause or the catalyst of cognitive decline and dementia, then treating hearing could have an effect on that pathway. So I'm just going to present to you very briefly some high-level results from the ACHIEVE trial. So the ACHIEVE trial was a randomized control trial looking at the question, can hearing intervention affect cognitive change? The population was 70 to 85-year-olds with and without substantial cognitive decline. They all had untreated hearing loss, and they were recruited via two key populations. So they were either a healthy de novo community, or they were from a study which looked at particular risk factors. And what they found with their primary analysis was that 3 years post-intervention, cognitive change didn't differ significantly between the intervention and the control groups. So the intervention group received hearing intervention, the control group received no hearing intervention. They had a healthy aging, intervention instead. However, when they looked at some plan sensitivity analysis, so looking between these healthy de novo and the at-risk groups, they found that actually hearing intervention might reduce cognitive change in those in the second group, in those at risk. So this is a kind of a landmark study where it could potentially show that hearing intervention can be beneficial, but but only if you're already on a pathway that was potentially put you at risk for developing dementia. Another study that I just want to highlight to you is the TACT feasibility study, and this looked at, can we run a randomised controlled trial of improving hearing aid use in people with mild cognitive impairment? So again, another at-risk community. So this study looked at a very similar personalised hearing intervention to the ACHIEVE trial. And the results of the feasibility study showed that the intervention has potential to improve hearing aid uptake and use in people with MCI and hearing loss. And that led to, well, paves the way, I guess, for the future RCT, which will look at whether that hearing intervention can mitigate cognitive decline in those at risk. So, moving forward, if we know that addressing hearing loss is going to be beneficial, how do we make sure that that's kind of implemented into hearing care where we account for dementia, and into dementia care where we account for hearing? So the first aspect of that is looking at the audiology pathway and to see what we can do to make sure that people who already live with dementia are properly cared for on that pathway. So aspects of this would include proper dementia training for audiologists, but also for reception staff and managers, anyone who comes into contact with patients. Development of clinical audiology guidelines for dementia-friendly assessment and management approaches, and also routes for ongoing care and support, including the integration of hearing and dementia care services. These are all things that we are striving towards in the field. And then in terms of improving dementia care to account for hearing loss, it'd be really great to implement guiding principles of deaf awareness in healthcare settings. And we've recently developed some guidance on this to promote hearing aid use for multiple benefits. So there have been 2 systematic reviews that show improved communication, quality of life, and reduced agitation in people living with dementia once they're fit with hearing aids, but also increased job satisfaction for health and care professionals who work with those patients. And it's really important to encourage early intervention for better outcomes, because we do know that dementia can interfere with the use of hearing aids, and it's already a challenging aspect of hearing intervention. So that's what we can do clinically. In terms of research, we've worked together with the James Lind Alliance, and my colleague Etna has led a top 10, which is just about to be published in Age and Aging. So these priorities have been developed from the ground up by people who live with dementia and hearing conditions, people who support them and their health and care professionals. And it has a representative steering group. Hundreds of people were involved over an 18-month period, and the top 10 research priorities are about to be shared with policymakers and funders of health and care research to bring the questions that would be the most beneficial to the people who will use the research to the top of the agenda for all of those aspects. Some of the example priority research questions that have been identified through this agenda are things like, should routine health checks in adults assess both hearing and cognition? And what aspects can people who have hearing loss take? What actions can people with hearing loss take to reduce their risk of developing dementia? Sorry, my words are all over the place today. And most recently, my interest in this area has been about kind of getting the message framing as good as we can in this area. So I was working with Hannah and a couple of international experts on getting the messaging right for the RNID website in terms of their facts and statements on health, and also working with the British Society of Audiology, BSHAR, and the British Academy of Audiology on some shared joint position statement and practice guidance on how audiologists can talk to patients about the link between adult onset hearing loss and dementia. So this kind of segues really nicely into me moving over to Hannah's part of the talk, where she's going to talk about messaging and the impact that has. But I just want to before I move to Hannah, I just want to thank the Hearing and Dementia research team in Nottingham, who are on this slide, and all of the people who've helped fund some of the work that we've done in this space. I'm going to move over to you now, Hannah.
Brilliant. Thanks very much, Helen. So yes, I'm Hannah and I work for RNID, which is a national charity that supports people who are deaf and have hearing loss and tinnitus. So it's really helpful that Helen's been able to give that overview of the current research landscape and this evolving evidence about the links between hearing loss and dementia. And what I want to do in this next part of the session is to take us from that science to thinking a bit more about the story that we tell about the science. And that's something that's really important to us as a charity, because we need to communicate that both to policymakers and people that are making decisions about both hearing loss and dementia and the kind of national agenda around that. But we also need to communicate this information to our communities and individuals who are thinking about what does it mean for them. So I want to talk a bit about how to, we think we can do that in a positive way that's going to drive forward positive change. It's going to be a bit Chris Whitty with me saying, next slide, please, to Helen. So if you could, there we go, brill. So because how we communicate this evidence really matters just as much as the findings from it themselves. So the words that we use and the way that we frame this risk around dementia and hearing loss can have a really profound impact on public understanding and also decisions about that our communities make and the actions that they take. And sometimes those messages can get distorted, particularly when they hit social media or are picked up by the press. And I'm sure it's not unfamiliar for some of you to have seen things like in the red box here suggesting if you put a hearing aid in, then you can prevent dementia. And it's as simple as that. And that's an attention-grabbing headline. But from what Helen said, we know that the kind of science and the messaging behind that is it's more nuanced, and there's more levels to it than just that. But we know that if we get this language right, then we can empower people to make positive decisions about their hearing. But if we get it wrong, then we can discourage people from taking action or cause confusion. So one of the biggest challenges that we face, particularly at RNID, is communicating that evidence at both the population level, so kind of public health messaging about the importance of the link between these two conditions, and then also the individual conversations that you might be having in a one-to-one consultation. And I'm sure there's a range of different people on the talk today where maybe you're more in one space than another, and the conversation and the messaging is different for those two groups. So at a population level, it's important that we can talk about the fact that untreated hearing loss is one of the modifiable risk factors for dementia, and the Lancet report has made it clear that that's something that needs considering and exploring further, and that's an important message for us to get across in terms of the case for better access to hearing care and earlier intervention and more investment in hearing health. But it's also important that we don't imply that every individual that has a hearing loss is then at higher risk of developing dementia, because the evidence doesn't support that. And that could cause fear and anxiety, and also lead people to make decisions based on misinformation rather than making an informed choice. So that's a balance that we really need to keep at the front of our mind as a charity, and perhaps depending on your background and the work that you do, that's important. One of the reasons for this is around the issue of stigma, and that's something we shouldn't overlook, because one of the unintended consequences of talking about the relationship between hearing loss and dementia is that we know that both of these conditions are strongly associated with aging. So if we're not careful, then we can be reinforcing the negative stereotypes about aging, frailty, cognitive decline in a way that causes people to be disengaged and be either trigger avoidance or denial. So yeah, then there's a risk that instead of us encouraging people to seek early hearing support, which is what we want people to be doing and to take action on their hearing, we put people off for fear of the stigma associated with these two conditions. So again, it's not about us avoiding the topic, but communicating it in a way that's helpful and supportive at an individual level. So on the next slide, please. We've done some research recently that highlights this. So our It Does Matter report has got some data around the evidence that stigma does still exist from a hearing loss perspective. So showing that people believe that they still hold negative attitudes towards people who are deaf and have hearing loss, and a large proportion of people agreeing that there is still stigma towards our communities, so people who are deaf and have hearing loss and tinnitus. And if you want to read that report in more detail, we can share the links to that later on. Okay, next slide, please. So then as a charity and a community, we need to be able to advocate boldly for hearing health and ensure that what we say is responsible, but we do want to be able to campaign about the importance of hearing health, and the link with dementia is a really strong part of that story as well. So at a charity, we see that we've got a responsibility for both to raise this profile of hearing loss and its impacts and links with wider health and well-being, but do it in a way that's grounded in evidence. So an example of when we've had to kind of overcome this challenge or think carefully about it is not that long ago, a couple of months ago, we were contacted by a journalist who had come across some data about audiology waiting times increasing, and they wanted to run a story that sent a very strong headline message saying something like audiology waiting times lead to increased dementia risk. And that's something that we just can't, that direct kind of causal message just isn't there. And also there's a risk there of causing fear and anxiety among people who may be waiting for an audiology appointment or a hearing test. So communicating it in that way, not so helpful. And so we're wanting to make sure that we have messaging that is appropriate. And then last slide, please, Helen. So despite, saying that there's some caution around this, obviously the science and the evidence is indicating that there is a link between these two conditions, and that we know that hearing care particularly isn't getting the attention that it needs within public health and social care, and it's under prioritised and under resourced, and it's not being talked about in the conversations that are shaping national health policy. And there's a real opportunity for us to change this and to change it in a right way. And we want to be able to communicate that one of the kind of driving factors for this is that we want to promote healthy ageing. So we want to be able to invest more in research and building the evidence base further, so supporting ongoing public education about hearing and it being seen as the priority that it should be. So one of the things that we often say at RNID is that people regularly get their eyes checked, and they don't think about they go to the dentist, they go and have their eyesight tested, but they don't think so much about routinely having their hearing tested, and building that kind of positive messaging that this is just a normal thing to go and have checked is something that's important to us. And if that also reduces the risk of some people developing dementia by acting on their hearing loss, then that would be a really great benefit from that as well. So just to end, I wanted to challenge people to have a think about what role dementia research and the clinical community could play in helping us to advocate for better hearing care, because of the links that we've been discussing today, and to think about how working together between the dementia community and the hearing community can help us to raise the profile of these two really important health conditions on the national agenda, and ultimately to improve people's lives. So that is the end of our presentation. Thank you very much for listening, and we've got some time for questions now.
Fabulous. Thank you so much, Helen and Hannah. So much really fabulous information shared. And the fact that so many people have come along today, I think only goes to prove that this is a really a really hot topic. You are our highest attendance of the year so far, so that's amazing. So there are some questions in the chat, so I'm going to go to those first. If you have a question, do start to type those in the chat, or if you would like to ask it yourself, then obviously feel free. I will endeavour to get to you before 3 o'clock if I can. So let's begin with Andrea's question. I wonder about the sensitivity and specifically of the adapted mocker and what would then happen as a result of using this routinely in an audiology clinic. Would it result in increased rates of false positive referrals into memory services?
So I can take that one if you like, Hannah. The sensitivity and specificity of the mocker HI has been published because it accounts for the verbal instructions not becoming an issue for people with hearing impairment. It should have complete direct translatability to people without hearing loss. So I would assume that the sensitivity and specificity would be equal. I don't know if it's been tested, but I would refer to the original article, and I can pop the reference in the shared slides that we're going to offer after the webinar. So I'm happy to pop that in there. But yeah, I can't see how there would be any difference between a hearing impaired versus a non-hearing impaired population. Ultimately, when we make things accessible, it benefits everybody, not just those with a challenge.
Absolutely. Thank you very much. Kate says, given the challenges that people who already work in the field of dementia face in terms of fully understanding dementia, getting the approach right and therefore supporting the individual as well as possible, would it not make more sense for this to be introduced to memory assessment services and community dementia nurse teams?
So by this being introduced, are we thinking about hearing assessment?
Assuming
Hi,
so.
Helen. Yeah. Hi, it's Kate. Yeah, just a quick. I already include it in my memory assessments in terms of making sure that people have had or when they last had a hearing test and highlighting, and we have done for a couple of years. So you mentioned sort of perhaps introducing a test, a cognitive test to audiologists, but we're already doing it.
So you're assessing cognition
during a memory assessment.
You're assessing
we do touch on the link between hearing and dementia, and therefore are asking, even if it's just getting the conversation into that sort of memory assessment setting. We've been aware of the link for quite some time. So in some respects, it would make more sense for people who are already trained to do that memory assessment to have the conversation about hearing, as opposed to the audiologist doing the assessment.
And I think that's absolutely the stance I would take. Why try and introduce a whole level of training and resource to a service that isn't equipped to assess cognition? Whereas actually the other way around, we have very easy to administer validated tests that could screen for hearing loss. So, and even just asking somebody about their hearing can often help.
Yeah, and just as a reassurance, really, it's already massive conversation in the field of dementia, or certainly where I work. It's been a huge conversation for probably longer than 2 years, to be honest, in terms of that link.
And just because it would potentially be acceptable and feasible to do doesn't mean it's the right thing to do. So testing cognition in an audiology clinic isn't something that I would recommend. I think it would be much better dealt with the other way around.
I think it's perhaps about that standardisation across all memory services, isn't it? Because we know there is variability. I do peer reviews of memory services, but I only see a fraction of them. And there is a lot of variation, and good practice isn't always replicated, which is really frustrating. Kate did also have a follow-up question a little bit further down the chat, which says, has the research involved MAS and CDN teams at all, or has the focus been on audiologists? I don't know if you've answered that, Helen, or
possibly. It was that was the next sort of follow-up, really. Has the research focused on audiologists, or have memory assessment services been included?
So research has been done in both respects. I can provide some references to that. I think we are certainly under the impression that less training and support would be required for the latter, so to provide hearing assessment in memory clinics. So I definitely think that's worth doing. We also have developed some practice guidance looking at what people can do across any healthcare setting to make their service deaf aware, and that includes looking at people's individual preferences for communication needs, and again, by implementing this across the board, accessibility is just going to be raised for everybody, not only those who have a hearing loss. So I think just really good practice on good communication, individualized communication, making sure that the person who's sat in front of you fully understands what you're saying from a hearing perspective. That's absolutely imperative to offering good care.
Super. Thank you very much. Thank you, Kate, as well, for coming off mute for a bit of clarification on those questions. Carol Ann asks, well, she doesn't ask so much, it's more a statement, but I think it's a really interesting conversation point. We have a big challenge with our dementia patients with wearing their hearing aids and misplacing them, hiding them. Now, do we have any advice or any good practice? I guess it's going to be put it in the same pot every single time and pull it out and have systems, but anything else?
So there is quite a lot that can be done. I think from the first perspective, if people are fit with hearing aids really early, so prior to their dementia progressing, they can get used to them much better. If they're fitted during disease progression or late in the pathway, then it can be much more difficult to kind of keep hearing aid use up. My colleague Graham Naylor's written a really nice paper on this topic. It's called Dementia and Hearing Aids, a Two-Way Street, I think the title of this is called. It will be in the reference list at the end. And I think there are many things that we can do to make hearing aids and the processes around fitting and supporting them dementia friendly. So there are some recommendations in that paper. But ultimately, it doesn't have to be a hearing aid. There are alternative amplification devices out there. So if hearing aids are not working for a particular patient, then maybe stop trying to kind of push something that doesn't work and look for alternatives, because there are alternatives out there. So there are different kinds of body worn or different types of amplification devices or personal amplifiers that can be used. But as long as the solution works for the patient, then kind of follow that route. So yeah, I think the integration of hearing and dementia services would just be absolutely the way forward to kind of make sure that all of these avenues are addressed.
Really interesting, Helen. Thank you. So we had our Creative Dementia conference last week, and we had Symphony Sound there. Pritesh is on the call today, and they put some fabulous sound equipment into the main hall. And I think university, everybody welcomed that, whether they had hearing difficulties or not. It was really, really useful. So Kate just makes an interesting point that I wanted to highlight from the chat. So she talks about being aware of a hearing aid and the initial echo in the first 24 to 48 hours. She's been told that this is one of the main reasons people don't persevere with wearing them. Any comments on that? Obviously, you would say, I guess, persevere.
Yeah, so it takes your brain quite a while to adjust to any change in sounds. So any audiologist, I'm not a trained audiologist, I'm a psychologist, but any audiologist that I speak to the advice would be to kind of persevere and to build up So to build up use of the hearing aids over the first few weeks until it becomes a point where it's second nature. So I had a personal experience of this. My nan received her hearing aids at the age of 90. So she was very kind of late in age by the time she sought some help for her hearing difficulties. And it was a journey of 2 weeks of me popping over in the evening and sitting with her while she learned to take them in and out. She got used to the sound, practice with them. And I thought, this is not going to work. She's never going to use them. And 2 weeks in, she said, right, that's it. I like them now and I can't live without them. And a couple of months later, literally, she was an advocate walking around and telling all of her friends to get to the audiology clinic. So it is just a case of getting over that initial hurdle. There are other things that people stop using their hearing aids for when they receive them. So the sound quality isn't always amazing for people. Their expectations are quite high. Sometimes people with hearing loss believe that if they get hearing aids, their hearing will be corrected. A little bit like when you have a prescription for your glasses, pop them on, you can see clearly. It's not the case with that, with hearing loss and with hearing aids. Getting used to them is challenging because the sound is different. It can't replace lost hearing, but what hearing aids can do is they can make sounds accessible again, and that can be absolutely life-changing once people get used to them.
Fabulous, thank you very much. Question from Jerry. How can you avoid problems with people who perceive you have dementia when the problem is you can't hear? I think it's what you talked about, Hannah, isn't it? That crossover between the two and those stigmas that exist.
Yeah, absolutely. And I think that is one of the real challenges, is not just from a kind of diagnosis perspective of making sure that we're not misdiagnosing one condition or the other, but also that public perception. And as a charity, the work we're doing around It Does Matter is trying to campaign to improve public attitudes towards people who are deaf and have hearing loss. And I suppose that's part of the puzzle, is trying to get people to break down some of those negative attitudes and to reduce that stigma through our campaigning work. But there's also the other side of that around dementia as well. And I think other dementia charities are doing some important work in that space as well.
Chat's getting flooded with questions, and there's one I absolutely want to ask, and I don't know if anyone will ask it, so I'm going to pose it now before I carry on with the chat. I want you talked at the end about raising the profile of hearing in social care and what that means. If you've got any ideas how people can do that, what you would want to see them doing to really start that conversation, short of sharing this presentation and obviously your resources and things like that.
Yeah, that's a good question. I mean, I think I'm looking at it and we're looking at it from a hearing perspective, but there's kind of trying to talk to the decision makers within that. But one of the most powerful things that we can do is to tell positive stories of the experiences that people have had, to really highlight the benefits that hearing aids can offer to people who have dementia. And I think regardless of there's the kind of evidence that we need to be able to back that up at a kind of policy influencing level, but there's also just the reality that giving people hearing aids and allowing them to have that social connection and to stay engaged is really important. So I think something that would be great is to share those stories more, and for us to hear from the dementia community and people that are supporting patients of when they've got examples when that's been brilliant and powerful, and we can use those as part of our campaigning, and also vice versa. So I think that's one aspect.
Yeah. The power of personal story is amazing, isn't it? Maybe we get to highlight this at UK Dementia Congress. I don't know, the call for abstracts closes today. Maybe we get to talk about it in November and sort of really highlight that. Anything you would add, Helen, on that?
Not to that one. I think that Hannah's done a great job of covering that quite comprehensively, but the next question I really want to kind of address is the one from Nikki Ward. I don't know if you want to read that out.
I was going to get to that one. So Nikki sent actually two messages, so I'll do the pre-text, the contextual bit first. So it's been an interesting, if not slightly scary, presentation. She has moderate to severe hearing loss and also works with people with dementia and their carers. So Nikki says, does the research take into account those with cochlear implants?
So yeah, there is quite a lot of work on people with cochlear implants. I think the thing to say here is the associations between hearing loss and dementia, typically age-related hearing loss or sensory neural hearing loss that develops over the life course. People who are born deaf are not shown to be at any higher risk of developing dementia than people who aren't born deaf. It's something to do with the degeneration of hearing neurology. So there's something going on there that's degenerative rather than anything to do with genetics of hearing loss from birth. What I would say to Nikki in terms of it being a scary presentation is not to be scared. By far, the biggest association for the development of dementia is age and genetics. So we're looking at a 7% risk here for hearing in the grand scheme of the 93 other percent that are out there. So there is a link, but I would not say that if you've got hearing loss, you are on a pathway to develop dementia. I think if you are on a pathway to develop dementia and you assess your hearing and you manage it, you will remain socially engaged, independent, and you will retain your cognition for longer.
And that's really highlighted as well by a comment we had in the chat. So Sharon said, when I got mine fitted, so her hearing aid, I heard the birds again and I cried, which I think it is just that reconnection, isn't it, with the world around you, whether that's conversation or whether it's the natural world. I've heard people talk about, hearing their grandchildren talking properly for the first time or whatever it can be. So Sen very helpfully says, in Luton and Bedfordshire Memory Services, we've been including this in our routine assessments for the last 3 years, which is great to see. And I think, I think the message from both of you would be all memory assessments need to be, delving into people's hearing status and making sure that is addressed. Kate raises the important point, person-centred care is core. Absolutely. It's about responding to each individual, isn't it? Nottinghamshire development prevention work. This is on topic. Lots of people who've got to go. That's no worries at all because we're nearly at the end. Kate says, as a person who is partial hearing and part of many groups as a chaplain, I flag and encourage folks to have hearing tests. And I think that would be a really great message to kind of end on, really, wouldn't it? If you've got a concern, go get it checked out. I did the RNID online hearing test. I don't know if anyone's put a link in the chat for that. I've actually got it up in my browser, so I'm going to pop a link in there because it's just a little starting point, isn't it? I don't think it's intended to replace at all, that in-person experience with an audiologist, but it's a place to begin.
Absolutely. And I think if we think about testing our hearing, we can pick things up early, but also for people living with the dementia, if we treat hearing loss, then that's going to have huge benefits for the individual, for communication, for behaviour, and for carers. So it's a double-edged sword, assess and manage hearing for multiple benefits.
Super, thank you. A final reminder from Kate, a reminder to bring hearing aids as well as glasses to memory assessments. An appointment letter is also helpful. Absolutely. And there's so much audiology in high street opticians now, isn't there? So you can kind of do a 2-in-1, get 2 appointments in one hit and get everything checked out. That's been amazing, Hannah and Helen. Thank you so much. My first tricky 2H presenters, and I've managed to mix it up on a few occasions, but lots of amazing information. Thank you so much. Do have a look at the chat because there's lots and lots of thanks from our audience today, and I'm sure this is going to be a very popular piece on YouTube as well. So thank you so much for all the information that you've shared today. So for all of our participants, it's been great to have you with us today. Do join us for the 3 webinars we currently have available to book onto before we take our August break. There is a link in the chat. You'll need to scroll up a little way now because there's lots and lots of lovely thanks in there. But you can come and hear about music in our next one. And then we have intergenerational and also environments being covered in July. So do pop along to our next webinars. We look forward to seeing you. And thank you so much for joining us today, and a final thank you to our fabulous presenters as well.